Beverly Hills Plastic Surgery Podcast. I'm Dr. J. Calvert. Dr. Millicent Ravello is with me today and has suggested the topic that already gives me chest pain. How are you doing, Dr. Ravello?
I'm doing pretty well. I apologize for giving you chest pain on a beautiful Friday afternoon, but this is an important topic, and it is one that probably should give you chest pain.
Implant malposition.
Oh, it just kills you when you see it.
And you know how hard it's going to be to fix.
And you're like, oh, gosh.
It's not simple.
There's
nothing easy about implants that are in the wrong place.
No. So what we're talking about are breast implants that have been placed yesterday, 3 months ago, 30 years ago. And when you see them, you know that they are in the wrong position. Although, I will say, sometimes the patients don't know that they're in the wrong position, which is always an interesting dynamic when you're like, so what bothers you about the implants? They're like, I just want to be smaller. I'm like, oh, that's what bothers you?
Okay. It's true. A lot of times the patients do not know that they have
realize
symastia, double bubble, total bottoming out.
Right.
They don't have, lateralization. I mean, I think when you lay down, if the implants roll into your armpits,
not
you
great.
should know that that's not right.
That's not normal.
They should go a little bit out to the sides. That's fine.
Yeah. But then they should stop.
Yeah, there shouldn't be, a 10-inch gap between the implants across your chest.
Right. And a lot of times that is how it happens. The patients come to you for removal, replacement, a lift, and not necessarily because the implants are in the wrong position, but then when you examine them, you obviously notice it and you're like, okay, this removal and replacement just got a lot more difficult. But sometimes the patients definitely notice it and they come to you and they're like, we have a problem here.
Yes.
So it can go both ways for sure.
So let's go over some of the situations that we encounter. First off, symastia.
Thank God it's pretty rare because it is a problem. Symastia is when you have, this is really a problem, you can have it naturally, but that's very, very rare. This is a problem that happens after implants, and it's when the soft tissue over the sternum or the center of the chest has been violated, and now the implants touch in the midline. Not necessarily touch, like it's not implant on implant. There's usually like at least some few layers of cells in between them, but it's not a much. You basically, guys, this is the uniboob. It's the uniboob.
That's it, uniboob.
Yeah.
It's where the pocket is basically across the sternum, and the implants they're seemingly in the same pocket.
Right.
Although you're right, typically they're not like touching.
But they're capsules. The thin layer of tissue around them is potentially touching.
Right. And fixing it ain't easy.
Fixing is not easy. And so there are a lot of different steps involved in fixing it. Typically, you have to find a way to close off the pockets on either side, create a brand new pocket, and then what I like to do is put another piece of mesh or some kind of dermal matrix in between there as well. And so what we're talking about is, say you have the implants above the muscle in a subglandular position. We're going to take the implants out of the subglandular position, make a brand new pocket under the muscle, or vice versa. And that gives you the best chance of really preventing it from happening again. Because if you use the same pocket and you just try and close it off with some sutures, there's a high chance that it'll come back and blow through those sutures. So you got to obliterate the old pocket, make a brand new one, and then I usually put that little piece of mesh that we talked about on that inside border to create another layer of preventing it from coming back. The tricky part, though, and tell me what you do with this, what do you do with that loose skin that has been raised up over the sternum?
That's hard. I typically stitch it back down. It's not easy, and you do have to do something with it. Otherwise, it
just stays lifted.
Yeah. So I will catch the capsular tissue. I don't go to the dermis, obviously.
Right.
And then try to stitch it down either to the rib cartilages up against the sternum